I was presented with a 61-year-old male patient who was complaining of widespread pain in his entire body, mostly in his neck, both arms, his entire spinal column, as well as both knees and left heel. He had circled every major joint in his body as well on the exam, complaining of his right hand not having any circulation. He'd been in the military as a youngster, but had been having terrible pain since the age of 17. He had a knee consult, but refused total knee replacement a few years ago. He does not want any treatment for his low back pain, and currently is on 6,000 milligrams of gabapentin a day and 8 milligrams of Dilaudid a day. He's on disability, walks with 2 canes, but does do some aqua therapy and massage therapy as well. His sleep quality is very poor. Gets up roughly every 10 minutes. Takes him over an hour to get to sleep. His pain is continuous at an 8 out of 10. And he's had some osteoarthritis, skin cancer, chronic fasciitis of both. Well, as far as history, I wanted to ask, was the heel pain worse in the morning? Was he having any night sweats or shortness of breath? Was the wrist pain worse in the morning? And basically any other treatments he had received in the past, such as steroid injections for his neck pain or even for his back pain. I was also curious if he'd had any workup in his sacrum dysfunction. Also wanted to see if he, going along with the SI dysfunction, if he'd had any x-rays or MRIs of the sacrum. I'm curious if his family had any diagnosis of ankylosing spondylitis. Had he seen a rheumatologist before? Did he have any history of gastrointestinal infections? Is the pain constant, or does it kind of exacerbate? Right, antalgic gait noted. We got the vital signs, temperature 97.2, blood pressure 140 over 87, pulse is 64, respiration was 18, height is 6 feet, weight of 85 pounds, general appearance, no distress, and wearing sunglasses. Get you to take your sunglasses off, stare straight ahead, conjunctiva are clear, pupils equal and reactive to light. No use of accessory muscles with respiration, no fasciculations noted. Muscles look well developed. Pulses. Posterior tibialis pulses are close to negative edema. Going to take a look at your fingers here. Digits and fingers are normal on both sides. Neck and head alignment looks normal. Spine alignment looks normal as well. Judgment is normal orientation, memory, mood, and affect, and contact is normal. Pessimistic attitude is noted. Get you tilt your chin down to your chest. Tilt your chin back. Tilt your chin to your side. There you go. Tilt your other way. Excellent. Turn your head over your shoulders. Excellent. And other way. Excellent. All right. Moderate pain noted in the flexion extension and right lateral bends. Range of motion is 45 degrees with flexion, 5 degrees with extension, 30 degrees with the lateral bends, 30 degrees with the right lateral rotation, and 45 degrees with left lateral rotation. Check here. No tenderness. Go ahead and tilt your chin to your chest. Any shocking sensation going down your arms, back, legs, the ribs is negative. Go ahead and relax a little bit. Positive Hoffman's on the right. Positive Hoffman's on the left. Go ahead and tilt your the waist. Lumbar flexion, no pain noted. Positive Sperlin's on the right. Negative Sperlin's on the left. Out like so. 5 out of 5 strength. 5 out of 5 strength. 4 trippers like this. 4 out of 5 strength. 5 out of 5 strength noted. 5 out of 5 strength noted. Excellent. Tendon reflex lenses here, just relax.
Lenses here,
Plus
just
2
relax.
brachial radialis.
Plus 2 brachial radialis.
Plus 2
Plus 2
plus 2 triceps.
Plus 2 triceps.
Plus 2
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 plus 2 plus 2. Excellent.
and plus 2. Excellent.
How about getting fun?
Tendon
How about
reflex.
getting fun?
Tendon reflex
Are good.
are good.
Let me check. Close your eyes.
Check.
Hold your hands
Close your
out.
eyes.
Let me feel when you
Hold your
touch.
hands out. Let me feel when you touch.
Yes, 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 yes. Yes, 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 yes.
All right. Diminished in the C6, C7,
Diminished
and
in
the
the
beat in
C6, C7,
Palmar
and the beat
areas.
in Palmar areas.
All right. Pinprick is diminished in the C6 and
Diminished
C7
in the
area.
C6 and C7 area.
Let me know when you feel the buzzing.
Let me know when you feel the
Tell me when it
buzzing.
stops, right?
Tell me when it stops, right?
Do you feel it, buddy? It just stopped. Feel it, buddy? It just stopped. Feel it, buddy? It just stopped. Feel it, buddy? It just stopped.
Diminished in the right foot.
Diminished in the right foot.
All right. I want you to go ahead and hold your
Go ahead and hold your
arm like that. Phalanx test is
That.
positive bilaterally.
Test
Right
is
is
positive
worse than the
bilaterally.
left.
Right
All
is
right,
worse
go
than
ahead
the
and relax
left.
your arm.
Go ahead and relax your arm.
Tunnel sign positive on the right.
Tunnel sign positive on the right.
Tunnel sign positive on the left.
Tunnel sign positive on the left.
Excellent.
Excellent.
Go ahead and hold the other arm over your head.
Hold the other arm over your
Excellent.
head. Excellent.
Checking for relief of pain with
Checking
the
for
shoulder
relief of
abduction
pain
test.
with the shoulder abduction test.
I'm
Excellent.
going to do
Doing
the distraction test.
the distraction
For
test.
relief of pain with that.
For relief of pain with that.
Thank you very much.
Excellent. Thank you very much.
Wanted to rule out cervical myelopathy as well as cervical radiculopathy and carpal tunnel syndrome. The patient showing potential for both cervical radiculopathy and carpal tunnel. I always worry about cervical myelopathy with any kind of cervical. His imaging from 2011 showed advanced facet arthropathy and degenerative disc disease along with spinal stenosis. Here are some diagrams showing the facet arthropathy that could be causing some radicular issues there. Obviously, with imaging findings, we could see degenerative disc disease, spinal stenosis, structural changes in the facets, radicular. I'm worried about ankylosing spondylitis just because of the onset of the pain as well as the systemic spinal issues and peripheral issues as well. His MRI showed bone edema, which could be found in patients with ankylosing spondylitis, as well as some of these issues. As far as his labs, I would consider getting an HLA B27 drawn. Radiology, I'd consider an MRI or X-ray of the sacrum to rule out sacroiliitis, and possibly another MRI of the C-spine due to the new onset of pain in the arm. Diagnosis: ankylosing spondylosis or spondylitis, C6 radiculopathy with possible carpal tunnel syndrome. Differential diagnosis with him complaining of the coldness in his hand. I was worried about CRPS and disc herniation, cervical myelopathy. Goals of any treatment is to improve function for the patient as well as decrease the pain level to an acceptable level. Patient's on a lot of opioids, so I would like to reduce that. For my treatment plan, I was wanting to, patient's currently in physical therapy. I wanted to maintain that as it is. Consider administering a different NSAID because he's allergic to or has an intolerance to ibuprofen and Aleve. So I was considering diclofenac. I was also considering consulting with the rule out carpal tunnel syndrome. I wanted to do an EMG if the patient did have a carpal tunnel syndrome on the right. Wanted to do surgery, possibly on the left, conservative, and consider an ESI for the cervical radiculopathy. Plan B, consider a surgery on the left if it is carpal tunnel syndrome. consider a neurological consult if the patient. If he's got ankylosing spondylitis, here are some things I would consider as well.